So surgery is a big deal. Postoperative pain after a surgery is one of the major complaints people have after surgery. Now there's a lot of different options we have. Pain management is a complex beast. Pain is a perceived experience to a noxious stimuli. So if you have a patient who's completely asleep and you poke them with a needle, they are not going to have pain. Why do I say that? They might have stimulation. Their heart rate might go up. Their blood pressure might go up. They might even move. However, pain is an emotional, a cognitive experience. So it involves the brain higher level processing. If somebody is under general anesthesia, I call it stimulation. In the PACU, when people are waking up, we call it pain. We don't call it stimulation. What's your stimulation scale? No, we call it what's your pain scale. So postoperative pain is a big deal. There's two major categories. There's narcotics. Now, narcotics oftentimes get a bad rap. They are strong medications. And then there are non-narcotics. Now, this is going to be a very, very basic lecture because there are a lot of different pain modalities out there. If I talked about every single one, I could talk about for hours and hours and hours. Now, narcotics on one hand, there are some very common narcotics that we use in today's clinical practice. So narcotics can be broken down even further into IV pain medicine and PO or oral pain medicine. Non-narcotics likewise can be the same thing. You could do intramuscular, you could do intravenous, you can do oral or PO. So there's a whole bunch of different options out there. So let's go ahead and talk about IV narcotics. Of the IV narcotics out there, most surgeries in today's clinical practice utilize two main drugs. One of them is going to be fentanyl. Now, nowadays on the news, fentanyl is getting a bad rap. Why? It's a very potent medication. A very small amount of fentanyl goes a long way. It's been around for decades. Almost half a century at this point. It's synthetically created. This is not a natural chemical that we found in the environment that we took and we said, oh, this creates pain. No, we actually created this as a human species. It's used intravenously. It works very rapidly, works just within a matter of seconds to a minute, and then it peaks at about 5 to 10 minutes, and then it starts to wear off. And some of it will go away within about an hour. There might be some lingering, but this is very rapid acting and a fairly short lasting IV pain medicine. The other common medication that we use is hydromorphone. Now, most people know this as Dilaudid. Hydromorphone is the generic name for this molecule. It is given intravenously. It does tend to be a little longer acting. Again, it is a narcotic. Both of them work on mu receptors. They both cause narcotic related side effects. These are not great ideal medications, but they are strong. They work quick. Intravenous medications are going to work a lot quicker than oral medications. Now, in the recovery area, you might actually utilize PO medications almost every single patient. Why? Because while the IV medications work quick, they also wear off quick. So if you introduce some PO medication, it'll give you a longer duration of action. So things like Oxycodone, for example. Oxycodone is a narcotic. It's a great narcotic used fairly often. You also have other medications like Lortabs. Again, this is more of a trademarked name. You have hydrocodone, you have oxycodone, you have hydromorphone. Dilaudid can be given in an oral form as well, so I'll throw this over here. So there are a lot of different oral medications, and if I went through the whole list, it would be quite extensive. However, I would say most of our oral medication is going to be oxycodone. You might even see codeine thrown in there. It's a fairly antiquated, dirty drug, but it is still around in clinical practice. So narcotics work. Now, narcotics can only go so far. They cause nasty side effects, constipation, and I'm not talking just, I'm a little constipated. I'm talking ileus, where your whole bowel shuts down, and you might go a week or even further without having any bowel movements. That causes a big congregation of stool, can cause some serious issues. Causes urinary issues, causes respiratory issues, cognitive issues. If you've ever taken a narcotic, it is a strong molecule. It does cause some issues. So then let's move over here to the non-narcotic medication. In my clinical practice, I try and marry narcotics with non-narcotics by doing a multimodal pain management strategy. Multimodal modal. By doing a multimodal strategy, I'm using some non-narcotics as well as some narcotics. By doing a combination of everything, you get some synergistic effects. Not just what the narcotics would give you, not just what the non-narcotics would give you, but a whole pain management solution. So there are some intramuscular drugs. In the post-op setting, everybody has an IV, or most everybody has an IV. So why would I give intramuscular medications? The only reason I'd give intramuscular medications is when I don't have an IV present, which is very, very rare in clinical practice in the surgery setting. IV medications, on the other hand, you've got some issues. So IV Tylenol, for example, or acetaminophen. IV Tylenol, acetaminophen is great. You dose it just like you would for PO medication. So you can give up to 1 gram for a full-size adult patient with no comorbidities. IV Tylenol works, just not great. Just like if you fall down and scrape your knee and you take some Tylenol, you know that the scrape's still there. It might just be a little bit less. There's also other medications like IV Ketorolac. IV Ketorolac, also known as Toradol, is a medication that can help out. You also have ketamine that can help out. Magnesium can help out. There's a whole bunch of different medications out there that can be administered intravenously to help out or to help augment pain relief in the post-operative setting. And lastly, there's going to be some oral medications as well. The one that's coming to mind is Tylenol. Everybody takes Tylenol. However, you also have other medications like gabapentin. Now, don't get me started on whether there is actual benefit in the post-operative period for a one-time dose of gabapentin, but this does sneak into clinical practice when you're dealing with multimodal analgesia. You also have, let's throw it under IV here, dexamethasone. Dexamethasone is a intravenous steroid, helps with some of the swelling. If you have less swelling, you have less pain. So that is another medication. So in the post-operative period, I just want you to know that there are a lot of different options. Not only will you most likely get some narcotic medication, if you have major surgery, it does come with major pain and major discomfort. It is appropriate to take narcotic medications in the post-operative period. Narcotics are okay when used correctly. If you're using them and abusing them against doctor recommendations, that's where issues occur. And then non-narcotic medications for pain are also clinically useful. They're used every single day in almost every single patient to some degree. Now, with that being said, there are other modalities like nerve blocks. In my practice, I do a lot of nerve blocks. Nerve blocks are peripheral regional anesthetic techniques that utilize local anesthetics like lidocaine, bupivacaine, ropivacaine to help nullify some of the pain caused from nerve-related transmission. So nerve blocks might be a component too, just depends on the surgery. So what I recommend is if you have surgery, just realize that you're most likely going to need to take some pain medicine in the form of narcotic, but also supplement that with some non-narcotic pain medicine. Good luck, everybody.